study with Empower 131, which we had heard from a press release prior to ASCO, was positive for an improvement in progression-free survival. This is the study design. This is the typical Roche one with 3 arms, but a kind of hierarchical statistical design that is bordering on sadistic in its complexity. But the standard arm is at the bottom. It's standard chemo here, carbo and nab-paclitaxel for the squamous population. Again, any PD-L1 expression from 0 to high. And after the carbo nab-paclitaxel for 4 to 6 cycles, supportive care, no maintenance routine, versus the same chemo with atezo and then atezo maintenance. And that was the primary investigational arm, and then there was a secondary investigational arm that would only be analyzed if the arm B was positive for overall survival. And this is with carbo and standard paclitaxel and atezo, so we might see a comparison of nab-paclitaxel to standard paclitaxel here. And the primary endpoints were PFS and overall survival by intent to treat. Here's the progression-free survival. We had heard this is a positive study, and it certainly is, with a more than doubling of the 12-month PFS and a hazard ratio of 0.71. So that's encouraging enough. There was no real differences among the groups. Basically, all of these subgroups, again, get a pretty comparable benefit regardless of age, performance status. Not a big difference in never smokers. You can see that, whoops. You can see that there's wide error bars there, so that doesn't mean much. Patients with or without liver mets did comparably better with the immunotherapy. So no real differences here. And when you look at PD-L1 expression, all of these groups got a benefit. It was greater in the patients with high PD-L1, hazard ratio 0.44 versus 0.70 in the PD-L1 low, and it's still pretty good, 0.81 when the PD-L1 negative. This is just shown separately here. So overall, it's strong, and it's strongest in the patients with high PD-L1. And here's the response rates, same kind of trend. Basically, there's a difference favoring the chemoimmunotherapy arm, 49 versus 41%, near doubling of the response rate in the high PD-L1 patients, and it kind of peters out as a difference as you move into the lower range. But the durations of these responses are all longer with immunotherapy. So that's good, but the overall survival was not different. And yes, there's a separation of the curves when you get out to 18 to 24 months, but with this much overlap for this long, I would venture to say there is no way that this study is going to ever come out as significantly better for overall survival. I don't know the crossover rate, so it's possible that this may be in large part because the majority of patients crossed over to immunotherapy. And if that's the case, I think it's a shame to punish Roche for getting nearly all of their patients standard of care immunotherapy at some point. But as it turned out, these studies being presented at the same ASCO, this one just suffers by comparison. Here you can see the overall survival by PD-L1, and it's a puzzling pattern of the high PD-L1 doing better with immunotherapy, the negatives doing a little bit better with immunotherapy, and the PD-L1 lows doing better with chemo, which frankly I would say doesn't make sense. And I think this is just the weirdness that can happen when you break down subgroups and look at them separately without huge numbers. So that's that, and I think it is an alternative. I just think based on what we have here, when you have one study that has an overall survival benefit and one that doesn't, there's a clear winner. One of the things that I've said in the wake of AACR and ASCO is you don't bring a knife to a gunfight and you don't bring PFS to an OS fight. So I think OS wins. So that I would say is now the prevailing standard is that you would consider monotherapy for the high PD-L1, not for the low PD-L1, and that would be pembro monotherapy. And I would consider chemo with pembrolizumab to be the clear winner for the low or the negatives, just a question of whether it's based on Keynote 189 for the non-squames or Keynote 407 for the squames. Here's another potential consideration and another Empower trial. It looks a lot like Empower 131, the same nested hierarchical design with the control arm. This has been presented for about 7-8 months in different iterations, but it was for non-squamous patients because it includes bevacizumab, and it was carbopaclitaxel bev followed by bev maintenance in the control arm versus carbopaclitaxel bev plus atezo in the primary comparator arm, investigational arm, and a second investigational arm of carbopaclitaxel atezo but no bevacizumab. And this was over 1,200 patients, non-squamous, and this trial did allow patients who have EGFR mutation or ALK rearrangement, but they had to have received and progressed on targeted therapy before that. So that's kind of how we typically treat these patients. Once you've exhausted the targeted therapy, you move on to treating them along the lines of first line, but if they were driver mutation negative. So what was presented at ASCO was the overall survival data, which had not been shown before, and this shows a survival benefit with the 4-drug combination of carbopaclitaxel, bev, and atezo, hazard ratio 0.78 here, and this includes the EGFR and ALK positive patients. And historically, one of the things that we've seen and heard is that patients with the driver mutation don't benefit from immunotherapy, and that really seems to be largely true for monotherapy given late on 3rd, 4th, 5th line. But this trial, I think the biggest contribution of it is that it forces us to step back and think, we may be wrong about that, because it's one thing that they were positive in the inclusion of these patients, but in the subset analysis, the patients with an EGFR mutation or ALK rearrangement didn't just do as well, they did really better than everyone else in terms of the benefit with the 4-drug regimen was hazard ratio 0.54 favoring the atezolizumab in combo with carbopaclitaxel and bev. They also saw a big benefit for patients with liver metastases. I would not say that that's clearly specific for this regimen, but interesting, and also a little more of a benefit in the patients with high PD-L1, but a pretty comparable benefit in the highs or the lows. So here is the results by PD-L1 subgroup. I just showed this in the forest plots. Hazard ratio of 0.7 in the highs, 0.8 and 0.82, so good enough. But the question is, in a world where we also have data in really the same population except for those with the driver mutation, Keynote 189 had a hazard ratio for survival of 0.49, and I would call that screamingly positive, and this was net positive. And the other thing is that I personally don't favor giving a taxane-based regimen or this 4-drug regimen. I feel that compared to carbo, pem, and pembro, all this regimen adds is neuropathy and hair loss, and I'm not inclined to do that. So what's also interesting about this is they had another arm that didn't include the bev, and that arm didn't do better. This is basically carbopaclitaxel bev versus carbopaclitaxel atezo, trending in the right direction, but not significantly better. Doesn't look as good as the 4-drug regimen. And in the patients with an EGFR mutation or ALK rearrangement, there was much more of a benefit in the patients who got the bev than in arm A, which was carbopaclitaxel and atezo. So I don't know if we should generalize that patients with an EGFR mutation or ALK rearrangement are going to do every bit as well with any of these chemoimmunotherapy combinations? Maybe, but I think we should be cautious about that when the comparison we have in this trial is that patients who got the Bev with their immunotherapy did really well, not so much without the Bev. And then there's IO with combinations, particularly Nivo and Ipi. This is Checkmate 227, a very complex trial, but Haas Borgai from Fox Chase presented a subset of this. This is just looking at the patients with PD-L1 less than 1%. It's about a third of patients, and focusing on the patients who got chemo versus Nivo and chemo. And this showed that there was a benefit for Nivo and chemotherapy in progression-free survival with a hazard ratio of 0.54 and a greater response rate and duration of response with the chemoimmunotherapy with Nivo. Whoops, that's interesting. This was specific, though, for patients with who had high tumor mutation burden. This is 44% of patients, and it's high TMB as defined by Foundation Medicine with a 10 mutation per megabase cutoff. So they looked at patients who got Nivo and chemo, and those patients did better than chemo alone, and Nivo and Ipi did better than all of those. But in the low PD-L1 but low TMB patients, they all came out the same. So this really seems to be a TMB specific finding. So the question is, should this be used?